welcome to the deep dive. Today, we're tackling malignant mesothelioma. It's a rare one, but aggressive, so really important to get our heads around.
Absolutely.
I got some great notes here, and the plan is to pull out all the key exam-ready info, make it clear, make it memorable.
Sounds good. So mesothelioma, fundamentally, it's a cancer of the linings, the mesothelium.
Right, the linings.
Yeah.
Like around the lungs.
Exactly, the pleura mostly. But also the peritoneum in the abdomen, the pericardium around the heart, even the testes sometimes.
Wow, okay.
And the main thing is just uncontrolled growth of those mesothelial cells.
Okay.
It's a tough diagnosis, poor prognosis often, limited treatment options.
And it's strongly linked to asbestos, right?
That's the one. Primarily asbestos exposure, usually from industrial settings. Think breathing in those fibers over years.
So mostly pleural, the lung lining.
Yeah, that's the vast majority. We're talking 80–90% of cases are malignant pleural mesothelioma.
Does it spread far? Like distant metastasis?
Interestingly, distant spread is actually quite rare. It tends to be more about local invasion spreading within the chest or abdomen.
Okay.
And it's worth remembering, because of the asbestos link, compensation can sometimes be a factor for patients.
Right, good point. So asbestos is key. How does that exposure actually, lead to cancer? It takes a long time, doesn't it?
It really does. There's this long latency period, often 20, even 40 years, sometimes longer.
10 years.
Yeah. So the fibers get inhaled or sometimes ingested, and they embed themselves in those linings.
Okay.
And they just sit there, causing chronic inflammation, constant irritation. Over decades, this damages the cell's DNA, causes genetic mutations.
Which eventually tips them over into becoming cancerous.
Exactly. Uncontrolled growth starts.
So who's most at risk? Which jobs?
You've got to think about industries with heavy past asbestos use. So construction, mining.
Shipyards.
Shipyards, definitely. Asbestos manufacturing plants.
Yeah.
Also living near those places, or even, sadly, family members exposed to dust brought home on clothes.
Makes sense. Are there other factors? Genetics.
They play a much smaller role. There's some genetic susceptibility, maybe previous radiation treatments, but asbestos exposure is overwhelmingly the main cause.
So that ongoing inflammation, the DNA damage, that's the core mechanism.
That's the core pathophysiology, yes. Starts in those mesothelial cells lining the organs. Asbestos drives the inflammation, the mutations accumulate, and eventually you get a tumor.
And then it grows from there.
Then it starts to invade nearby tissues. It can spread to the regional lymph nodes, too. Distant spread is less common, as we said, but local invasion is a big problem. It's quite a complex process at the molecular level, too.
Okay. Now, you mentioned it's a tough diagnosis. What else could it look like? What are the differential diagnoses?
Yeah, the symptoms can be pretty nonspecific, so it can overlap with other things. You absolutely have to consider primary lung cancer, especially in smokers.
Right.
Also, metastatic cancer that's spread to the pleura from somewhere else. And then there are benign asbestos-related diseases like asbestosis, which is lung scarring, or pleural plaques.
And even other rarer pleural tumors, like a solitary fibrous tumor.
Yeah.
So you need to rule those out.
Got it. Let's talk numbers. How common is it, say, in the UK?
Well, because of all that past industrial asbestos exposure, the incidence in the UK has actually been rising for decades. We think it probably peaked around 2020 or might still be peaking.
And who gets it, typically?
It's mainly older people, usually diagnosed age 65 or older, and significantly more common in men because of that occupational link.
Any specific figures?
Yeah, it's still rare overall, but for UK males, the rate is around 3.4 per 100,000. That translates to about 2,700 new cases each year. And sadly, deaths rose dramatically over the decades, from maybe 150 a year in the late 60s to around 2,400 by 2012.
That's a huge increase.
It is, and it highlights that latency. Over 80% of cases are linked to known occupational asbestos exposure. Interestingly, only about 20% of mesothelioma patients also have asbestosis, the lung scarring.
Okay, that's a key distinction. So what symptoms should make someone or a doctor suspicious? It depends where it is. For pleural mesothelioma, the most common type, think chest pain, often quite persistent. Shortness of breath or dyspnea, a persistent cough, feeling really tired, fatigue, and unexplained weight loss. Those are the big ones for pleural.
And if it's in the abdomen, peritoneal.
Then you might get abdominal pain, swelling, maybe changes in bowel habits. For the very rare testicular type, it would be a mass or swelling there.
Are there any early warning signs, or is
Yeah.
it usually caught late?
Unfortunately, it's often caught late because the early symptoms can be really vague. Things like just loss of appetite, maybe a dry cough, nothing specific.
So by the time symptoms are obvious.
It's often quite advanced, yes, but some clinical features are suggestive. Finger clubbing can occur, sometimes even without obvious asbestosis.
Right.
A painless pleural effusion fluid on the lung is found in about 30% of cases. And of course, that strong history of asbestos exposure, often 30, 40 years prior, it typically presents in the 6th to 9th decade of life.
Okay. And on examination,
Hmm?
if there's fluid.
If there's a pleural effusion, you'd expect to find maybe decreased breath sounds on that side. The chest might not expand as much when they breathe, and it sounds dull if you tap it percussion. And abdominal distension could point towards peritoneal involvement.
So if mesothelioma is suspected, what's the workup? What tests are done?
Imaging is the first step. Usually starts with a chest x-ray. That might show an effusion or thickening of the pleura.
Okay.
Then a CT scan is crucial. It gives much more detail, confirms the effusion or thickening, might show a distinct mass or even invasion into the ribs. MRI and PT scans can be used too to assess the extent of spread regionally or distantly.
And you definitely need tissue, right? A biopsy.
Absolutely essential. You need a biopsy to confirm the diagnosis and figure out the histological subtype. They use special stains, immunohistochemistry to look for mesothelial cell markers.
Any other tests?
All tests.
Fluid analysis?
Yeah, blood tests might look for markers like mesothelin, though their role is still evolving. And if there's pleural fluid, analyzing that fluid is important.
Can you walk us through that diagnostic process quickly, like step by step?
Sure. So suspicion might arise from the chest x-ray. Then you get a pleural CT. If there's fluid, they'll likely drain some for analysis, pleural fluid aspiration. But just looking at the cells, the cytology from the fluid often isn't enough. The yield is quite low, maybe 20–30%.
So what then?
So increasingly, if cytology is negative but suspicion is high, they'll go for a procedure called local anesthetic thoracoscopy, or VATS, video-assisted thoracoscopic surgery. This lets them look directly at the pleura and take targeted biopsies. The yield is much higher, around 95%.
Right.
Or if the CT shows specific lumps or nodules, they might do an image-guided biopsy using ultrasound or CT to guide the needle.
And the fluid itself, what does it look like?
It can be straw-colored or sometimes blood-stained. As I said, cytology might sometimes clinch the diagnosis, but usually that biopsy is needed. They'll also do lung function tests like FEV1 and DLCO, especially if surgery is being considered.
Okay, clear. Imaging, fluid, and definitely biopsy. How is mesothelioma staged then? Briefly?
Staging basically describes how far the cancer has spread. It uses the T&M system, but broadly it goes from stage 1, where it's confined to one part of the pleura, through stages 2 and 3, involving more extensive spread within the chest, like the diaphragm, the lung itself, maybe lymph nodes on the same side,
Okay.
all the way to stage 4, which means it's spread to the other side of the chest, distant lymph nodes, or other organs. Higher stage means more advanced disease.
And given how advanced it often is and the poor prognosis,
Yeah.
what's the management approach?
Yeah, sadly, because it's often found late, a lot of the management focuses on symptoms, and quality of life palliative care is really central.
Right.
And as we mentioned, pursuing industrial compensation is also an important aspect for many. In terms of active treatment, there's chemotherapy. Surgery might be an option, but only for a small subset with very early localized disease, typically stage 1.
So the outlook is generally quite poor.
Yes, the median survival is often quoted around 12 months, maybe a bit longer in some cases, but it is generally poor.
You mentioned surgery. What kinds?
There are 2 main approaches, both pretty major. One is extrapleural pneumonectomy, or EPP. That's radical, removes the whole pleura, the lung on that side, part of the diaphragm, and the pericardium.
Wow.
The other is pleurectomy with decortication, or PD. This aims to remove all visible tumor from the pleura, covering the chest wall, diaphragm, mediastinum, and the lung surface, but it spares the lung itself.
Which is better?
It's debated, but the best survival outcomes seem to be in patients who can have surgery that achieves a macroscopic complete resection, meaning all visible tumor is removed, usually combined with chemotherapy and sometimes radiotherapy, multimodality treatment.
Okay. And chemotherapy. You said that's a mainstay.
Yes, chemotherapy can improve survival and helps manage symptoms. The cornerstone is platinum-based chemo, usually cisplatin or carboplatin combined with another drug called pemetrexed.
Any issues with those drugs?
Cisplatin can be tough on the kidneys and cause significant nausea and vomiting. Carboplatin is often used as a slightly less toxic alternative.
What about radiotherapy?
Its role is a bit debated. Sometimes used prophylactically on procedure scars to try and prevent tumor seeding, though evidence is mixed. It can be used after surgery or chemosurgery for local control. And it's definitely effective for managing pain, like from chest wall invasion.
And for fluid buildup.
That's a huge part of palliative care. Draining the fluid thoracocentesis provides immediate relief from breathlessness. And then pleurodesis is often done where they instill a substance, usually talc, into the pleural space to try and stick the linings together and prevent fluid reaccumulating.
So summing up, the prognosis generally poor, but what influences it?
It is poor, yes. Factors include the stage at diagnosis earlier is better, obviously. The location peritoneal sometimes does slightly better than pleural. The cell types, some subtypes are more aggressive than others. And of course, the patient's overall health and how they respond to any treatment they have.
What are the typical survival times again?
Average is often cited as 6 to 18-month median survival, but it varies hugely. Advanced stage, older age, poor performance status, these all point to a worse prognosis.
There was a UK stat mentioned.
Yeah, a concerning one. For patients diagnosed in England between 2013 and 2017, the estimated 10-year survival was only 2%. It really highlights the need for better treatments. Regular monitoring and supportive care are incredibly important.
And finally, what complications can people face?
They really vary depending on where the mesothelioma is and how advanced it gets. Respiratory problems are common with pleural disease, difficulty breathing, low oxygen levels, eventually respiratory failure.
Right.
The pleural effusions we talked about can recur. Infections are a risk. Pain is often a major issue. Severe breathlessness, cachexia, that's severe weight loss and muscle wasting. And in advanced stages, you can get organ failure. Plus, the treatments themselves have complications, surgical risks, chemo side effects, radiation effects.
So palliative care is key for managing those too.
Absolutely. A huge part of palliative care is anticipating and managing these complications, relieving symptoms like pain and dyspnea, and just supporting the patient and their family to maintain the best possible quality of life.
Okay. This has been a really thorough, deep dive into a very challenging condition. So to summarize, malignant mesothelioma, rare, aggressive, overwhelmingly linked to asbestos, difficult to diagnose early, challenging to treat, and sadly carries a poor prognosis overall.
Exactly. Understanding that asbestos link, the long latency, the typical presentation, and the diagnostic pathway is crucial if you're going to suspect it in the right context.
Well, thanks for breaking all that down so clearly. It's vital information. And for everyone listening, for more high-yield MSRA revision, do check out pastthemsra.com and freeisra.com.